because sometimes you get patients who come with relatively straight teeth and still want orthodontic treatment. And you think, well, if I can't really see a problem, it's highly unlikely I'm going to be able to give you the outcome you want.
Hello, you're listening to the Dental Protection Podcast, and this is the In Dentistry series where we are looking at diagnostic errors, which are often the drivers for the cases and claims that we deal with for members. The series of podcasts is focusing on different clinical areas of practice and looking at some of the specific issues that arise and how these might be avoided. My name's Yvonne. I'm Deputy Dental Director and Dental Underwriting Policy Lead. Now today I'm delighted to be joined by Dr. Jigar Patel. Jigar is a specialist orthodontist and is currently the clinical lead and consultant orthodontist at East and North Hertfordshire NHS Trust. As well as working in a secondary care setting, Jigar works in specialist orthodontic practice and is certified and experienced in a range of orthodontic systems, including ceramic fixed braces, Damon self-ligating braces, lingual braces and clear aligners. Jigar enjoys teaching, lecturing and is an examiner for the Royal College of Surgeons. He is also a current member of the Board of Dental Protection. Now, in this episode, we're focusing on alleged diagnostic errors that we see in cases involving orthodontic care. Everyone working in the field of dentistry will be fully aware of the boom and demand for orthodontic treatment and provision of services. And one of the specific challenges that we tend to see in terms of our orthodontic cases and claims is that it can actually be many months, in fact, it can be many years before an error in the diagnosis at the outset actually comes to light. So, for example, it might be the outcome of treatment doesn't meet expectations, or it may be that treatment actually ultimately was more complex than had been anticipated, and patients may end up undergoing courses of treatment that actually last a lot longer than had initially been planned. But as a starting point, when we look at orthodontic cases and claims, allegations relating to diagnosis can actually start a long time in advance of the treatment actually being delivered, and actually sitting with a practitioner who's not involved in the delivery of orthodontic care itself. And one of the common kind of failure or delay in diagnosis issues that we see, particularly impacting primary care dentists, is about the timing of referrals and making sure patients are referred appropriately, particularly an issue for child patients where interceptive treatment might prevent the need for more complex care, for example, ectopic canines. So, Jigar, first of all, I wondered if we could just touch initially on kind of this aspect of orthodontic care and whether this is something that you're seeing where patients are being referred perhaps later than an optimal time, which might tie into initial delay or error in diagnosis.
Thank you for having me on, Yvonne. Generally, at the moment, from my perspective, we're not really seeing a delay in referrals as much as we used to in the past. I think since COVID, there's been a backlog at the receiving end of referrals. So what we're finding is a lot of the specialist practices and hospitals are having a delay in seeing the patients that have been referred. What I would suggest to the dentists who are undertaking the referrals is that most general dental practitioners should really be aware of the expected developmental milestones for their patients. And the role of the dentist is really to spot the unusual happening and to refer as appropriate. This means that they should really know the eruption times and ranges for assessing normal dental development. They should be checking that their patients have the correct number of teeth. They should check that the eruption pattern is symmetrical and expected at the age of the patient. And if there's any abnormalities, it's worth undertaking a radiographic examination. Reasons why they might want to refer earlier than in the permanent dentition could be if they see delayed dental development, if they notice teeth are ectopic, if they want an opinion on poor prognosis first molars, if they want to have their patient assessed for early interceptive treatment for crossbites, and in some cases for early functional treatment. In terms of canines that you touched on, I think it's important that dentists do palpate for the canines around the age of 10. And generally, they should be palpable in the buccal sulcus around this age. If they cannot palpate the canines, it's worth taking a radiographic assessment to see where the canines are. And interceptive treatment where you remove the retained primary canines can be helpful if you notice that the permanent canine is in a position to benefit. So if the permanent canine is in a good position and removing the primary canine would help eruption, then it's worth doing. However, if the canine is more ectopic or unfavorably positioned, so it's moved across the route of the incisors, then it's probably worth not removing the primary canine, as it probably won't help. So it does take a bit of judgment. And if unsure, it's probably worth a referral to an orthodontist to get an opinion. And if a practice doesn't have facilities for DPT radiograph, they can refer to the specialist orthodontist to undertake that examination.
That's really helpful. And it is that uncertainty about what's the right path to go down. So getting that support is really important. I suppose one of the knock-on effects of COVID is that, perhaps the window of opportunity to refer patients at the appropriate time is a lot narrower because the patients haven't been attending for regular care. So whereas previously we might have been seeing the patients every 6 months, some of these particular child patients may not have been in the practice for a couple of years. So there may be a lot shorter opportunity to actually make the correct decision about referral. So perhaps just a time for being a little bit more vigilant, for looking out for those anomalies and making that referral when needed. I suppose that's a knock-on effect that you're going to see a lot more in secondary care over the next year or so. Now, I suppose on the theme of referral, the other area for those involved in provision of orthodontic care is actually that, orthodontics is such a challenging area of practice. And I know from my own experience that malocclusions that perhaps appear less severe can actually be quite complex to treat. And that's a skill that you need to develop, is actually ensuring that you can identify which are going to be the complex ones, which are within your competency, and making sure you refer patients appropriately when it's something that falls outside your skill set. So I suppose my question to you as a specialist is, with your experience, what are the factors that could actually make a case more complex and might be missed by a practitioner, perhaps somebody who's early on in the career or just starting out on that orthodontic journey?
That's a great question. And I think really it's usually the factors that get overlooked or missed are the ones that come back to cause the issues. It can be due to a failure to recognize certain aspects of the malocclusion, such as center lines being shifted, or correctly assessing the level of crowding or spacing, and then having a judgment as to what the impact of correcting the crowding or spacing would have on the rest of the occlusion. It could be a failure to recognize underlying skeletal discrepancies and take this into account when planning treatment. I try and follow a systematic orthodontic assessment approach. And I think this would be beneficial to all practitioners, because if you follow a protocol or template, then you are less likely to avoid any key features of a malocclusion. So the way I would approach it is to start with an extraoral assessment, look at the skeletal features in the AP dimension, vertical dimension, and transverse dimension, and then assess the soft tissues, i.e. lips, for competency and lip level. I would then assess the intraoral features, looking at the incisal relationship, the overjet, the overbite, the teeth that are present, the level of crowding and spacing, and the molar and canine relationship. Finally, I would assess the periodontal condition and the biotype. And I think this is particularly important in patients undergoing Invisalign treatment, where Invisalign is moving the incisors in a bodily direction rather than tipping movement. And I particularly look at the periodontal condition and gingival biotype for adult patients, because in these cases, I feel any labial movement of the lower incisors could result in gingival recession. Invisalign is useful because there is a superimposition tool on the ClinCheck where you can look at the tooth movements at the start and at the end, and you can superimpose a grid which will show you how much labial movement you are going to end up with in the lower incisor region. From that, you can make a judgment call as to whether it's an acceptable amount of movement or it's not acceptable, because you may end up with gingival recession, in which case you could ask the technician to make modifications such as interproximal reduction or a bit of expansion in the buccal regions to avoid this. The other thing I'll touch upon is that most orthodontists will undertake radiographic assessment prior to starting any sort of orthodontic treatment. And the reason for this is you get to see the full dentition, you see the bone levels, and you can assess the root lengths and the morphology. When I was doing my specialist training, it was quite common to undertake lateral cleft radiographs for all cases as well. Now, this is particularly important and helpful for learning because I can then fully understand how a case was treated and corrected. With more experience, I don't tend to take lateral clefts as much, apart from when I feel that they could alter my treatment decisions. And the reason I think for that is I am able to assess the incisor inclinations and skeletal bases better just through clinical assessment. However, that has come about with experience and training. And I think if you're starting out in orthodontics without that, it probably is more helpful to have more information than less to avoid any errors. The other reason I now take lateral clefts is only where I feel it would benefit a change in treatment planning. And these types of cases are those where you've got an underlying skeletal discrepancy, and knowing the incisor inclination would give you the information to know whether you can camouflage a malocclusion or whether it would need more intervention, i.e. surgical correction.
That's kind of a really helpful kind of overview and checklist of, I think there's so many different factors that, we forget unless you do that structured assessment, you can very easily miss something. You did mention, the benefit of radiographs and looking at roots. And, one of the factors that we see in some of our higher value claims in orthodontics is cases where patients are subsequently identified with root resorption. I think one of the challenges there is that we don't know whether it's actually the orthodontic treatment in itself that has kind of been related to that development of root resorption, or particularly for adult patients, was the root resorption there already? Should you ever have gone ahead with the treatment? And it's having that baseline kind of record. But I just wondered your own thoughts on, are there any red flags in terms of identifying patients at higher risk, particularly in relation to root resorption? I suppose, what would you look out for, and when would you step in and take an X-ray?
So in terms of red flags, I think the way I approach my patients now is the first thing I look for is, can I identify the problem as they see it? So when a patient comes to you and they say they would like to correct their malocclusion or they'd like to straighten their teeth, I try and look and see, can I see what they're talking about? Because sometimes you get patients who come with relatively straight teeth and still want orthodontic treatment. And you think, well, if I can't really see a problem, it's highly unlikely I'm going to be able to give you the outcome you want. So that then leads into the next point, which is, can I meet their expectations, or are their expectations realistic and achievable by myself? If they are, then it's okay to proceed with treatment. If not, this is where you might want to refer on to somebody else. Factors that make cases more difficult. I think there are more difficulties with treating an adult patient than a child patient because you don't have growth on your side. So when you're treating an adult, your treatment aims have to be more realistic. And you have to bear in mind that tooth movements can be slower in adults. They tend to have restorative dentistry, and so you might be working around crowns, bridges, and implants. And they may also have periodontal issues such as gum recession and bone loss to contend with. In terms of the risk of root resorption, that is something which I think is out of the control of orthodontists. And because all patients can be at risk of root resorption, that's something that we always discuss with patients during the consent process. The risk factors that we look out for are, one would be a family history of root resorption, because we know if there is a family history, then there's a higher chance of the patient having the risk of root resorption. The second thing we look for is any radiographic features. So if a patient has had orthodontic treatment in the past and you notice that they've got shortened roots, that's a red flag to say, well, further orthodontic treatment is highly likely to cause more root resorption. Other features you can see radiographically would be short roots or thin roots. which would then put them at a higher risk of root resorption in theory. And also, if they were to suffer root resorption with short roots, this would have a greater effect because they've already got short roots to begin with. So any further loss could exacerbate the prognosis of their dentition. If you can identify these features, I think it plays into how you then manage these types of patients. So if I have a patient where I feel they have a risk factor for root resorption, I will approach a treatment plan differently. What I tend to do is start with alignment only with round wires, and then take a mid-course radiograph to assess how the teeth have responded to the initial alignment. If you then notice that the patient is suffering from root resorption, you can work to compromise treatment aims and finish your treatment in round wires, avoiding any sort of root talking forces. And I think that's a more cautious approach to take rather than going direct with extractions and trying to do a full correction when you have a risk factor for root resorption. Because once you commit to extractions, you've got nowhere to go really apart from stopping treatment and then leaving a patient with spaces. So I think when you identify risk factors for root resorption, you need to put some steps into place to manage that. And I think if you start something simple or work to compromise aims, you can then deliver a result for a patient without compromising the potential long-term prognosis of their dentition.
Yeah, I think a lot of it is about the discussion at the beginning. And, if you've identified that risk, then you can have a very open discussion with the patient and they understand that risk and they're not embarking on anything without understanding the potential. And obviously the option of doing nothing is always an option for these patients. So, the importance of getting that diagnosis correct is so critical, these kind of patients. And I just wanted to move on because I said at the beginning that, a lot of the cases and claims we see, it's only a period of time after the orthodontic treatment is actually completed that problems actually start to be reported. And a common area that we see is actually in relation to failure of retention and relapse of the treatment. And then questions are asked about why this has arisen and was the treatment provided actually correct in the first place. In some of the cases, we're seeing failure of bonded retainers and ultimately movement of teeth. And there can sometimes be a friction between the patient and maybe the clinician as to why the bonded retainer has failed, with the clinician maybe saying it wasn't appropriate care by the patient. The patient thinks it's actually the retainer that was at fault or the treatment wasn't correct. So I'd just be interested in your own thoughts about issues that are more likely to lead to failure of a bonded retainer. And do you have any tips yourself for how do you reduce that risk of retention failure?
So in terms of bonded retainers, I think the first key thing is having a good technique when you're placing the bonded retainers. So good isolation, good moisture control. And once you've placed it, to check that you've got no heavy contacts using articulating paper. My personal preference is to use direct bonded retainers rather than indirect lab-made retainers. And I tend to use the FlexTech Gold Chain. The reason for this is I prefer it to the Twist Flex wire, as there have been cases in the past where patients have had partial failure of a Twist Flex bonded retainer. The wire has sort of tended to unwind and cause some unwanted tooth movements where it sort of kicked out the roots of the incisors. And with the FlexTech's Gold Chain, it's more passive if it debonds. It doesn't put any active forces on the teeth. The other reason I tend to use it is if it's directly placed, I can repair it and replace it chairside. So I don't have to wait for any laboratory work to arrive or any delays. I tend to now use transbond as the composite rather than flowable because I find this has the better balance of strength and flowability whilst placing it. And I always provide removable retainers as well as bonded retainers. I think it's inevitable that a bonded retainer will fail at some stage. And I tell the patients if they have a bonded retainer, they are also committing to maintenance. So they must be aware that they'll have to go for regular maintenance, cleaning around the bonded retainer, and the potential for it to debond and need rebonding. in the future. So I give them Essex retainers as a minimum, and then the bonded retainer is an optional extra, if you like, for the patients who prefer it. In terms of placing the bonded retainers, I tend to prefer to put my bonded retainers in before I remove any fixed braces. The reason I tend to do this is I like to fit the bonded retainer and then do the finishing and occlusal settling around this so that there are no heavy contacts on the upper fixed retainer. I know a lot of people will debond the appliances and then fit them, and it's fine for the lower fixed retainer, but in the upper, it's sometimes difficult to place a fixed retainer because there might not be the interincisal clearance to place a fixed retainer in the ideal position. And this leads on to another problem in terms of long-term maintenance. A lot of patients are discharged from their orthodontist and will see their general dentist for maintenance or repair of their fixed retainer. And if a patient has lost or broken a fixed retainer and there's no longer the interincisal clearance, it can be difficult to repair or replace this. And I have heard from practitioners where they've tried to help a patient and repair the fixed retainer, only to find that they can't put it or place it or repair it without causing an occlusal interference, which the patient then is unhappy because it doesn't feel like it used to feel. And so there is a growing difficulty in getting access to a practitioner or practitioners willing to look after and maintain fixed retainers long term.
Yeah, that's a challenge. And, I can understand that sometimes there may be a reluctance to step in case, a replacement of the bonded retainer is seen to cause problems. But I think ultimately, if you are going to see a patient who needs a replacement retainer, it's all about, making sure that you do that assessment and keep clear records showing, what the position of the teeth were at the time, what you discussed with the patient. And if there is any contraindications that, you get further input, whether it's from specialists. But yeah, I think, patients are going to be in a difficult position if they can't get somebody to just keep an eye on their retainers and have to keep travelling back to the person who did the original treatment. And then finally, I think, we've talked generally about the different areas of orthodontic care from diagnosis to kind of post-treatment care. I'd just like to end, I suppose, with kind of what your tips would be for somebody who is starting out on their journey in orthodontics. So perhaps a general practitioner who's, looking to try and introduce this into their practice. And what would you say to them in terms of trying to help ensure diagnosis is correct and reduce the risks of adverse outcomes?
I think for someone starting out in orthodontics, I would suggest they start initially with the more straightforward cases. Most malocclusions are class 1 malocclusions, so it's easier to manage. And I think if they start with the simple alignment cases, these are more straightforward to manage. I would suggest that they undertake a systematic orthodontic assessment approach, do a full orthodontic assessment, and produce something like a problem list, which they can then go through with the patient and identify the features that they can correct, and if there are any features that they feel they cannot correct. So the patient can then decide whether the issues that can't be corrected warrant a referral to a specialist or not. Because there will be a patient who's perfectly happy to have their teeth aligned and accept a little bit of an overjet. And equally, there might be somebody who wants to have their teeth straightened and reduce the overjet, which might require extractions or more complex treatment with fixed braces or different appliances, which could then be referred. So I think if you've identified all the issues, gone through each one and identified what you will be able to correct and what you won't be able to correct, that's giving informed consent. And you've given all the options available to a patient to weigh up and choose what they prefer to have done. It is difficult knowing what patients want to do, because often myself, I have patients come in and you ask them what they would like and they say, I just want nice straight teeth. And they don't know dental jargon like we do. So they can't say to you, I would like my overjet reduced, etc. What they mean when they want nice straight teeth, they've seen the brochures, they've seen the typodonts and the posters around the practice, and they probably want their teeth to look like that sometimes. And if you don't have a discussion about the features you can and cannot correct, what you might find is you have a patient where you've align the teeth, and that was their concern to begin with. But then they've noticed the overjet once the teeth have straightened, because a lot of patients focus on the issue that they first see. And then once that's been resolved, their eye then shifts to another problem. And I think this is a problem not only dentists would have, but specialists have it as well. The benefit to specialists is that they can do mid-course corrections. They can then, extract teeth to reduce the overjet or use a different appliance to get that goal. And I think if you're starting out in orthodontics and you don't have knowledge or skills of using an array of appliances, if you're limited to one type of appliance, I think it's worth having that discussion and making sure the treatment goals and aims are discussed at the start to avoid this issue happening later on.
So, yeah, Jigar, I think you've hit the nail on the head there that, what we see in a lot of our cases and claims is actually that patient expectation and understanding of what treatment is going to provide isn't actually what they get. And it is, the overjet seems to feature quite heavily in that, they don't understand what an overjet is. So when they're told your teeth will be straight, but the overjet won't be corrected, it doesn't mean anything to them. So there is a whole piece about communication and making sure patients really understand what treatment is going to achieve for them. I'd just like to say thank you to you, Jigar, for giving up your time today and just for sharing your expertise and all the valuable tips and advice you've given us in relation to orthodontic treatment. And thank you to our listeners for listening to the podcast today. Just as a note, if you're a member of Dental Protection and want to know more about today's topic, then please look in the podcast description for further information. For those who are new to podcasts, perhaps you're listening to this for the first time, make sure you subscribe to the channel to make listening easier in future. You can access this podcast from all major apps, including Apple and Google Podcasts and Spotify. For more information about Dental Protection, or if you're already a member and want a certificate for listening today, please look for details in the description. I've been your host, Dr. Yvonne Shaw. Thank you again for listening.